Good evening, everybody. Welcome to this case presentation. Nishant has kindly agreed to be the examiner and moderator, so I'll hand over the some proceedings to him. Thank you, Nishant.
Thank you so much for the opportunity, sir. A very good evening to everyone. So today we will be presenting a case of a swelling in front of the neck. Now, I must admit I'm not a routine examiner, but I have presented a lot of cases, and as a student, probably I will try and share my point of view as to what all you need to ask or what all should be missing, so on and so forth. And of course, we have Ravi Shankar sir here with us who will always step in and help us whenever necessary. Now, this presentation, I have not made any changes because if we come with a completely well prepared presentation and present it in front of you, there's no fun in it. So instead, we will go step by step, see what all we have missed, what all we have not missed, and how exactly the pro forma should be, and then we will take it forward. So today, my intention is to try and concentrate more on the clinical aspect of the case presentation. Now, when I say that I've not changed or made any changes to the presentation, I mean it because even my name is wrong. I noticed it, but I didn't tell Nikita. Okay. All right. Nikita, you can start.
Sorry, sir. Good evening, everyone. So, the case of 42-year-old male who is by profession at a desk job and resident of Bangalore. He came with the chief complaints of swelling in front of the neck since 10 days. Patient was apparently all right 10 days back and noticed a swelling in front of the neck. It was not progressive, not associated with pain, no history of fever, dysphagia or dyspnea, no history of hypo or hypothyroid symptoms, no history of hoarseness of voice, cough, hemoptysis, no history of weight loss or loss of appetite. Past history patient is not a known case of any medical comorbidities, no history of previous surgeries, no history of irradiation to head or neck, no history of similar complaints in the past. Family history not contributory, no bowel and bladder disturbances, adequate sleep present, no addictions, not on any medication. To summarize the history, a 44-year-old male of clinically euthyroid state presented with non-progressive swelling in front of the neck, noticed 10 days back, not associated with pain and pressure symptoms.
Okay, Nikita, see, don't use words like he's a desk job. I think that's very derogatory. You should say he must be a clerk or whatever it is. I think you can just say he's a secretary or whatever. Um, Assistant to somebody or whatever. Don't use the word desk job, which is a derogatory thing. Second thing is the patient complains of a swelling in the front of the neck, not in front of the neck. So this is very important because my professor used to say, he would come and stand in front of you and say, I am standing in front of you, so I am the swelling in front of the neck. So it is in the front of the neck. It is a small thing, but you should correct yourself. And second thing is thyroid and all that you should not use when you are talking about history. When you are talking about history, you should, present it in the patient's own words. When you come to clinical examination, you can use technical words. So don't say thyroid.
Okay, sir.
With no symptoms of hyper functioning of the thyroid. If you want to use that, okay. I think it is safer to use
Yes.
that way rather than because patients won't be able to say I am euthyroid. So history is always in the patient's own words.
Thank you, sir. Very, very important point what sir made, Nikita. If you think, sir, some point does not give you any importance for your case presentation, like does occupation have any role in thyroid or, swelling of the neck?
So, stress is the important factor, one of the important factors to
For
consider.
what? Stress is for what? Are you there?
Yes, sir.
So what
It's
is
more
stress
seen in
risk?
the toxic goiter situation, stress. It was mentioned, so I considered.
Yeah, better not to, because we'll be talking more about primary and secondary hyperthyroidism and stuff like that. So normally stress doesn't come. It acts as a trigger factor. That's all in women and all. Don't get it into this as much as possible. Otherwise, the questions only define the type of desk job and all. So better not to get into that. So in your case, you're saying that the swelling is there only since 10 days.
Yes, sir. Noticed since 10 days.
Okay. What all do you think could be the possible swellings that can appear in front of the neck, in the front of the neck?
Most common are the thyroid swellings first, then thyroglosal cyst,
Okay.
uh, cervical lymph nodes, sir,
Okay.
and
Can you have
sebaceous
some
cyst,
subhyoid bursas? You can have dermoid cysts.
dermoid cyst.
Yeah. So next time, don't prepare only for thyroid. So because you all keep your mind open. Can you move on to the next slide, please? Now, in 10 days, do you think the swelling can progress?
It can progress, sir.
Can you tell me in which scenario it can suddenly increase in size like that over 10 days?
If there is any hemorrhage in the swelling, it can suddenly increase in the size.
Excellent. And can the same thing also cause pain?
Yes, sir.
And what are the other causes of painful thyroid swelling?
If it is
Think of some.
if it is involving or pressing onto the
No, no. 10 days, ma, history. So,
Suddenly
think
the
of
pain,
thyroiditis, sir, inflammatory changes.
inflammatory thyroiditis.
thyroiditis can
Dangerous,
cause
dangerous
pain.
thyroiditis.
Correct. Decoverate. Correct. Now, you've gone on to ask for history of fever. How common is history of fever in relation to thyroid swellings?
It is seen in thyroiditis, sir, but very rare.
So then why have you put it up first? Do you think dysphagia and dyspnea is more common with a thyroid swelling, or do you think fever is more common?
Dysphagia and dyspnea, sir.
Yeah, and is there any correlation to those three, like fever, dysphagia, dyspnea? I'm just asking because you put all three in a line.
Like upper respiratory tract infections and sore throat,
They are related to?
throat, sir, not.
Yeah, no, I'm asking, how is it related to the thyroid? It
Sir,
can cause
dysphagia and
thyroiditis, right?
dyspnea are related in case. Yes, sir.
See, you can defend, I'm not saying no. But how many cases of thyroiditis have you seen in your post-graduation life?
One, sir.
Yeah, out of so many thyroids, only one. So don't mention this upfront. Okay. Instead, what are we looking for when we ask for dysphagia and dyspnea? Or even hoarseness of voice for that matter?
We are looking for the involvement of the nerve, sir, recurrent laryngeal nerve, and pressure.
Involvement?
Involvement of vocal cords for the voice change, sir.
Yeah, it is not
For
involvement,
the
it is
dyspnea,
pressure. Pressure.
pressure.
Why did I say it's not involvement? Why did I say it's pressure? What is the difference between the two?
Involvement is supposed to be infiltration,
Mhm.
but pressure could be just from the outside, could be a benign pressure also, sir, without
Okay.
any infiltration.
So why is infiltration rare?
In case of malignancies,
Yeah, why is infiltration rare? Pressure symptoms, I completely agree. Whether it's benign or malignant, in both scenarios, I believe pressure symptom is more common than infiltration of the nerve.
due to the presence of capsule around the thyroid, sir.
What capsule?
Capsule which is formed by the deep cervical fascia, pretracheal fascia, and
True or the false capsule? That's what I was asking.
yes, sir.
The
False
one which is
capsule.
correct. Correct. It's a very tough and a dense fascia which doesn't allow the infiltration of the thyroid. Okay. That's the reason you get more commonly a pressure symptom rather than infiltration. So going forward, next time, I would rather like you to first present about the swelling, then the onset, the duration, the progression, then go on to pressure symptoms. After that, move on to the next line of whether your patient is having hypo or hyperthyroid symptoms. Now, can you quickly enumerate few hyperthyroid symptoms and few hypothyroid symptoms? What did you ask the patient?
Sir, to rule out hyperthyroid, we asked about the increased appetite, any irritability like increased sweating,
Mhm.
and heat tolerance, sir.
Heat intolerance.
And this heat intolerance, yes, sir, heat intolerance. For hypothyroid, we looked at the poor appetite, weight gain, and lethargy or weakness, and if there is any facial swelling, and also if the skin is dry.
Those that don't come under symptomatology. Those are all findings that you're going to look for in your examination. Now, when you told me about hyperthyroid, can you classify them a bit more? You kind of gave me a bunch, and majority of them fell into one category and didn't fall into the other. Can you try to put it a bit better?
System wise, sir.
Yeah, not exactly. Yeah, system wise only. Tell me.
Sir, like cardiovascular features of hyperthyroidism would be palpitations, tachycardia.
Tachycardia won't come because
Whereas,
it's not a symptom.
yes,
So, okay, tell me the other serious symptoms that the patient will have.
the
Palpitation.
neuromuscular symptoms would be irritability and nervousness, sir,
Wait, listen to me,
and
listen to me.
sleeplessness, tremors.
Listen, Nikita, listen. I'm asking you serious symptoms because you
Yes,
skipped it completely when you told. So, what are the serious symptoms? And I tell you why I'm specifying it. One is
there
palpitation.
would
What are the
be
others?
orthopnea, sir, and
Dyspnea on
dyspnea.
exertion, orthopnea, pedal edema. As in, of course, you will not, you won't ask them edema, but you'll ask them swelling of the limbs. Why? Why does the patient have orthopnea, pedal edema, dyspnea on exertion, and all?
Cardiac decompensation, sir.
What decompensation? What is the terminology? Praveen,
Cardiac failure, sir.
what type of cardiac failure is it? Cardiac failure with hyperdynamic circulation. Even though the heart is pumping more, it gives way. Okay? Okay. So what I was trying to tell you is, it will be better when they ask you a question to classify it as symptoms suggestive of primary thyrotoxicosis and symptoms suggestive of secondary thyrotoxicosis. In primary, which symptoms are most common? Nikita, are you there? Did I lose connection? What's happening?
Hello, sir.
You're there? Okay.
Yes, sir. Yes,
Yeah.
sir.
So in primary thyrotoxicosis, what are the predominant
New
symptoms? Which system is involved?
neurologic neuromuscular system is more involved in primary, sir,
Correct. So
and eye
excitability.
signs are more seen in primary.
Okay, so excitability, irritability, insomnia. So when you're telling the examiner, if he asks you to tell me, it will be better if you can put it as symptoms suggestive of primary thyrotoxicosis, the user CNS symptoms, then symptoms suggestive of secondary hyperthyroidism or thyrotoxicosis, and you can put it that way. Yeah, this is better. Okay.
Yes, sir.
Somebody in the, we will ask some first year, Sai Likith. Okay, Samir.
Yes, sir.
Can you tell me what is primary and secondary hyperthyroidism? Are you there?
Sir, primary will be thyroid gland itself is producing like too
Okay,
much of
secondary?
hormone. Secondary is overstimulation by the pituitary, sir.
No, no, no. Oh, okay, I understood what you're saying, but could you put it a bit better? Anybody else? Praveen?
May I,
Sir,
sir?
when, when long-standing solitary goiter or multiple goiter shows thyroidosis, then it is secondary. Sir.
Correct. Okay. So in short, if it is the thyroid itself which starts working more, either because of hyperstimulation or autonomous like antibodies which act and they cause initially hyperthyroidism symptoms which eventually lead to an enlargement of the goiter. So first symptoms, then goiter means primary hyperthyroidism. In secondary, what happens because of the fluctuating TSH levels, you'll end up with nodules of the thyroid. And eventually, because of the fluctuating repeated stimulation of these nodules, the nodules become autonomous. Okay, and then they start secreting excess amount of thyroid hormones. So this becomes secondary hyperthyroidism. So that means here first swelling followed by symptoms. And invariably, secondary hyperthyroidism will be associated with multinodular goiter because of the fluctuating TSH levels. Only then you're going to get multinodular. Diffuse goiter with hyperthyroidism more likely to be a primary hyperthyroidism. Any doubts or questions? Okay. Nikita, last question. Why did you ask for weight loss and loss of appetite? Is that common whenever we see a patient with thyroid neoplasm?
It is routine for the thyroid as well as for the neoplasm, sir.
It's routine for?
It is routine for the thyroid swellings to look out for the hypo and hypothyroid symptoms.
If you have already mentioned it, why have you mentioned it separately again?
To
Why
specify
special
regarding the
treatment for only
neoplasm,
these
sir.
two symptoms?
As a part of neoplasm history, sir.
Correct. That's why I asked. So how common is it that you find weight loss and loss of appetite associated with thyroid malignancies? Is it common or no? Like CA
Nikita,
stomach,
It
you
is
see
common,
patients,
sir,
right?
because of the yes, sir.
Nikita, what is the classical symptoms that you describe for hyperthyroidism?
Sir, increased
Weight loss,
appetite and
weight loss
weight
despite a
loss.
good appetite.
Yes, sir.
Despite a good appetite. That's what you say. So, what Nishant is asking is rarely do the malignancies are hypersecreting. Most of them are usually euthyroid or hypothyroid. So, weight loss is never usually not a symptom of malignancy. That is what he was trying to tell you.
Yes, sir.
Got it.
And second thing, Nikita, most of the thyroid malignancies, they are differentiated. Okay, the most common is the differentiated. That means they act almost like a normal thyroid gland. So even though they're advanced cancers, very rarely patient will have weight loss and loss of appetite. Okay, that's more commonly seen with patients with like other malignancies, GI malignancies and stuff like that, but very unlikely with thyroid malignancy. There is a saying, if God comes in front of you and says, choose a malignancy, the answer should be thyroid. Okay, go ahead. Next
Yes, sir.
slide. Why did you ask for history of previous surgeries? What were you looking for?
Any history of hemithyroidectomy, any thyroid surgery in the childhood, sir, or any?
Okay, now if my scenario, let us say the patient has undergone a surgery in the neck. Will that be in past history or will it be in present HOPI?
Sir, it might have had happened somewhere in the childhood, sir, history. So
Simple question. Now, let us say this patient has undergone a surgery. 5 years, 10 years, okay, 20 years back, he's undergone a surgery in the neck. Okay. With this history, will you put it in the HOPI or will you put it in the past history? It should be in the HOPI,
Past
right?
history only, sir.
No. Anything, if you think that history is important and related to this particular scenario, it always goes into the HOPI. Okay. So if it's a negative history, like history of previous surgeries, completely omitted. Now, please just think about it. Now, your patient has history since 10 days. Do you think that a previous surgery can be associated with this condition?
10 days, yes, sir, is associated.
How? No. I think I'm
It could be
confusing you a little bit. See, this patient has noticed only since 10 days, but he's undergone a surgery in the neck, let us say 20 years back. Can that surgery and this swelling be associated with each other? Can it be recurrence? Let us say he's undergone some surgery for
It can be
malignancy.
recurrence.
Correct. So if it's a recurrence, your history will start from 20 years back or it will start now. Won't you dig in more information from him? Won't you ask him, did they send it for biopsy? What was the report? Did they make you drink some
Yes, sir.
medicine and get a scan done? Won't you ask all this information?
Sir, if it is a positive history, it goes into the HOPI.
Correct. If it's a negative history, please omit it.
Okay.
Otherwise, you'll end up
Okay.
digging more and
Okay,
more,
sir.
like they'll take you down a path which you're not prepared for. Same thing with history of irradiation to the head and neck. What history or what were you trying to ask?
Sir, we are trying to ask whether he had undergone any ionizing radiation,
For what
any
condition?
previous treatment was taken,
For
something like
what condition?
skin disorders or any
For skin disorders, they give radiation.
some minor doses of irradiation from skin disorders to the deeper structures. It depends.
Okay. So what is more common, Nikita? Why do you want to get into skin? Then they'll ask you what are the skin disorders where you're going to give irradiation.
Dental, yes. If patient has any dental issues and
So you're asking like an X-ray of the tooth can cause
like
this. Why not a chest X-ray for pneumonia? Won't you be exposing the neck, looking at the trachea? Why can't that cause thyroid malignancy then? Yes or no?
yes, sir. It could be either for adenoids or tonsils.
Okay. Adenoid tonsil, at what age do they operate, Nikita?
Childhood, sir.
Correct. And do you
At
think
age of age
irradiation
10.
that back will cause some swelling now 10 days when he's 40 years old?
No, sir. It might have precipitated now, but it's just an exposure when the patient had.
Lymphoma, no? In the neck, why else will they give radiation? Okay, lymphoma can give, they'll give radiotherapy, not your X-rays and exposure to dental X-rays or chest X-rays and stuff like that. Okay? That mantle
Okay, sir.
radiation, whatever, if they've undergone a neck dissection, they give radiotherapy to the neck, right? Again, here also, if
Yes,
it's
sir.
positive, mention it. If it's negative, I would prefer to omit it out because there are a lot of other things in which you can discuss rather than go down this lane. Please do not say this adenoid tonsil and all. As far as I know, they don't give radiation. I may be wrong, but please look it up. And second thing is, if I'm not wrong, if the duration of exposure between your radiation and this current symptom is more than 20 to 30 years, it is very, very unlikely that the two are linked. So if you are telling the radiation is given when the patient is 5, 6 years of age and now he's 40 and it's coming now, very, very unlikely these two are linked. Okay. And next, again, this history of
Okay.
similar complaints in the past. Better to avoid. What complaints are you asking? Like similar complaints in the past, which has come, which has vanished and come back again now. What can it be?
It could be like inflammatory conditions, sir. Any cyst which is resolved or
Can a cyst resolve? Doesn't have to be aspirated. Again, Nikita,
It
same thing.
might have said,
If it is a cyst or your thyroiditis, it is resolved and it is come back. So will your history start from this coming back phase, or will it start all the way from up top? If you
sir,
think it's
this
important
point
in
is
this
very
condition,
confusing, sir.
don't put it. I'm telling you,
So
all these
you,
are not necessary. If it
okay,
is,
sir.
if it is like, let us say, patient has undergone hemithyroidectomy, now he's developed a nodule in the opposite side. Fair enough. Very, very important history. Put it in the HOPI. You can start off saying the patient had a swelling for which he underwent a surgery. Now, 5 years later, he was all right. Now the swelling has come back, and then start the rest of the presentation. No examiner will say, oh, why did you ask that first? They will not do that. But if you ask questions like this, they'll keep on digging more and more because they know that this is irrelevant. Instead, I would have I would have wanted you to ask the patient one more piece of history. Did you ask if he has any similar swellings elsewhere in the body? Now you're so confident it is thyroid. You told me it can be cervical lymph nodes also, right? One of your DDs. Now we have already
Yes,
made
sir.
up our mind it is thyroid, even without seeing the examination. Yes or no?
Yes, sir.
So far, everything is negative. Patient only has swelling. There is nothing else. So did you ask if there are swellings elsewhere in the body?
No, sir.
Should you ask?
Yes, sir. Yes, sir. I was supposed to.
Correct. So can you tell me, apart from cervical lymphadenopathy, in relation to thyroid, what could be those other swellings that I'm talking about? With you have thyroid swelling. Apart from that, can the patient have extra swellings?
Not sure, sir.
Anybody else?
Follicular
Bonus
neoplasm
swellings,
with
skull, ribs.
pulsatile
Correct.
metastasis.
Come on, man.
Before that, which is the most common malignancy? Which is the
See,
most common thyroid malignancy? Boys, come on.
Papillary, sir.
Ah,
Sir.
so papillary spreads to what?
Lymph nodes.
So can't you have
Lymph
one
nodes.
thyroid and an adjacent cervical lymph node? Did I say it is not in the neck? I only asked if there are other swellings in the body. Is neck not part of the body?
Neck is a part of,
Yes, sir.
yes, sir.
and
Why
other
shouldn't you ask?
differential diagnosis, lymph nodes, for example, if there are neck nodes, you can have groin nodes, axillary nodes, all these things. So I think that is what Nishant was trying to get at. Nishant, the only thing is
Yes, sir.
the history of irradiation, if it is present, it has to be said.
It
Whether
has
it
to be there,
is,
sir. That
yeah,
I'm not denying. If it is not there, it is better to avoid it rather than put it up saying there is no irradiation, especially with a dicey history where it is only 10 days.
yeah.
If it is there, any of these, whatever you have mentioned, if it is positive, please mention. If it is not there, there's no point in highlighting and telling the examiner you know it. So then you can ask, they'll ask you, why did you even ask this when you know they are not related? So my personal preference would be to avoid it. But of course, if the examiner asks, did you ask? Sir, I asked, but I didn't write it. You can always defend. They will not fail you for that. Okay. Now, Nikita, if this is a female patient, what extra would you have asked?
About the menstrual history, sir, but in the
Correct.
Yeah,
So
menstrual history.
now let us assume it's a female patient. What specifically are you asking for in the menstrual history?
sir, is there any amenorrhea or menorrhagia, sir?
Only two options, nothing else? All or none phenomena, or can there be something in between also?
Oligomenorrhea also.
Hmm. Okay. In which condition will you get oligomenorrhea? Which condition do you get menorrhagia with relation to thyroid conditions?
Sir, hypothyroidism will cause menorrhagia,
Okay.
whereas hyperthyroidism can cause amenorrhea and oligomenorrhea.
Can you explain why that happens? If you don't know, we'll ask somebody else because we'll
No,
run
sir.
out of time otherwise. That's why. Anybody else? Praveen? don't unmute and keep quiet. If you know, tell me, otherwise I'll
No,
give the
sir.
answer. We can go ahead. Okay, simple. See, let us start with hypothyroidism. In hypothyroidism, what happens? TSH is increased. Now, TSH is released from pituitary, correct? So, along with TSH, little bit of FSH, LH also gets secreted. Second thing is the beta component of TSH is similar to the beta component of FSH. So, this acts on the on the ovaries, increases the amount of estrogen. Eventually, the patient is going to have menorrhagia. Now, the same thing the other way around. In hyperthyroidism, TSH is low, so the pituitary is suppressed. So at the same time, even the FSH, LH also will get suppressed. The patient will have oligomenorrhea. Another theory, I don't know how valid it is, but the other theory is that in hyperthyroidism, all smooth muscles go into a stage of spasm and contraction. So the blood vessels in the endometrium run in between the smooth muscles. So when the smooth muscles clamp down, they tend to reduce the blood flow to the endometrium. So therefore, not much of shedding. So oligomenorrhea and amenorrhea. Okay. So these are the explanations, but please go read it up. These are important questions that will be asked. Okay. Rest all percentages, how you're going to manage, you will get to that only after you clear this stage. Can you please move on to the next slide, Nikita? Oh, no bowel bladder disturbances. What bowel bladder disturbances can be there?
Sir, in hyperthyroidism, there is a chance of loose stools or increased bowel activity, sir.
Fair enough. Okay. Now, what medication are you interested in asking?
Whether patient is on any thyroid medication or any beta blockers.
How will
to
you
know,
ask
sir.
that in history? Why only beta blockers or, sorry, what was the other thing you asked him? Beta blockers or?
Thyroid medication, sir.
There are
Either
two types of thyroid medication. Yeah.
yes, sir. Either anti-thyroid medication or thyroid hormone.
How will you find out this on history? Patient does not know. Let us say patient is not a desk job, is a farmer. He tells they're giving me some medications. Is there a way
That
from
he's
his,
having it in the morning.
correct? Go ahead.
In an empty stomach in the morning, if the patient is having, most probably it could be a thyroid medication, sir.
Okay. And if it's anti-thyroid, what is the dosage? How do you treat hyperthyroidism? Does he take it 3 times a day or 2 times a day?
New work
That's
3
all.
times a day, sir.
If it's a single dose on an empty stomach in the morning, more likely to be a thyroid supplementation. If it is 2 times or 3 times a day, more likely to be a anti-thyroid medication. In anti-thyroid medication also, if you want to dig more, neomercazole usually comes in a bottle. If you want extra history, you can tell that also. Okay, if you want to show off. He takes 3 tablets from a bottle, then other 2 tablets from a strip, all that you can add if you want to. But I'm saying there are ways to get that information out of the patient through history itself without anything extra. One last question. I think I missed this when we were talking about hypo or hyperthyroidism. Can a patient have both the symptoms, hyper and hypo, if not at the same time at different times?
Yes, sir.
Can you give me a scenario when that can
In case
happen?
of thyroiditis,
In case
in
of?
case of the thyroiditis, there is a thyroiditis, sir.
Hmm.
There are two
Which
phases,
thyroiditis?
hypo and hyper phase.
Which
Hashimoto
thyroiditis?
Hashimoto's
thyroiditis.
thyroiditis.
Why? Why does the patient have both the symptoms and what is the pathophysiology?
Due to breakdown of follicles, thyroid hormones will be released initially, so it will be transient hyperthyroidism.
Hmm.
Then, due to destruction of follicles and not regeneration, it will goes to hypothyroidism.
Excellent answer. So the first phase is called as hashitoxicosis. So basically what happens is if somebody is angry, they want to vent out. If you go and try to tell them reason, they will not understand. So in thyroiditis, the thyroid is inflamed and angry. It will only vent out. That means it will give out thyroid hormones, but it is not in a condition to take up iodine. So it will give out, keep on giving out the hormones. So patient is in hyperthyroidism. But for how long can it give? Till the reserves become empty. Then patient will become euthyroid. Now, when it wants to take up iodine, problem is all the cells have been destroyed and replaced by lymphocytes. So now it can't take up iodine. So from euthyroid, eventually it will go into hypothyroidism. So Hashimotosis, euthyroid, hypothyroidism. This is the pattern what you're going to see in Hashimoto's thyroiditis. Okay. So you have summarized saying it's a 44-year-old man of euthyroid state. Stop this. You have already dictated that it is a thyroid. First, say 44-year-old man comes with a swelling in front of the neck. It moves with deglutition. You can ask the patient. He'll tell, Nungdaga mele kelige hogutta. He'll say yes. You can add that to the history. Moves with deglutition. No symptoms suggestive of hypo or hyperthyroidism, and you can stop it. Okay. That will be the way you're going to word your summary. Ravi Shankar sir, anything extra to be added in history level, sir, before we move on to examination?
No, I think it's been covered. Thank you.
Any doubts from anyone before we move on?
Yes, sir.
Yeah, ask for. Oh, you said no, sir. Okay. Nikita, please go ahead.
Coming to the general examination of the patient, patient is conscious, coherent, and cooperative, well built and well nourished, no eye signs or exophthalmos, no pallor, icterus, cyanosis, clubbing, koilonychia, lymphadenopathy, or pedal edema. Skin appears to be normal. Patient has no hand tremors, no signs of Horner syndrome. Vitals, patient is afebrile, pulse rate of 88 per minute, regular, blood pressure 120 by 80 mmHg, respiratory rate 20 per minute, saturation 99% on room air. Systemic examination not contributory. Local examination, patient is examined in a well-lit room with adequate exposure and verbal consent. Examination is done from front as well as from back with and hands behind the head of the patient. On inspection, a solitary swelling of 5 into 4 centimeters is seen in front of the neck, involving the right lobe of thyroid. Left lobe and isthmus are not visible. Swelling extends from the midline to the sternocleidomastoid from the level of thyroid cartilage to 2 centimeters above the level of sternal notch. Surface appears to be smooth. Swelling moves with deglutition, doesn't move with protrusion of tongue. Skin over the swelling appears to be normal, no scars or dilated veins. No other swellings noted. Trachea appears to be central in position. On palpation, there is no local rise of temperature, no tenderness elicited. Inspectory findings as confirmed as 5 into 4 centimeters solitary well-defined swelling with regular margins and nodular surface, firm in consistency. Swelling felt extending from midline to sternocleidomastoid from the level of thyroid to 2 centimeters above the level of sternal notch in right lobe of thyroid. Lower margin is felt, left lobe and isthmus not palpable. Trachea is central in position. Carotid pulsations felt on both sides and normal site. No cervical lymphadenopathy, no cervical lymph nodes felt bilaterally. Percussion over the mandibular sterni is resonant. On auscultation, no bruit heard. To summarize the examination, a solitary swelling of 5 into 4 centimeters noted over right lobe of thyroid, well defined with lower margin felt, nodular surface, non-tender, moving with deglutition with no cervical lymphadenopathy.
Yeah. Can you please go back to the first slide of your examination, Nikita? Okay. First things first, before we go ahead, please do not present the examination findings as right lobe and left lobe of the thyroid. If you're already telling it's a thyroid, then there is no point giving the other information. It moves with deglutition. If you've already decided it is a thyroid when you're presenting, there is no point in presenting the case. Okay? Present it like a swelling. Swelling in front of the neck, so and so centimeters from where it to where it is, etc., etc. Do not use the word thyroid. This would be my personal preference. Ravi Shankar sir, is it okay for them to present it as the right lobe, isthmus, and left lobe separately like this when they're presenting in the exam, sir?
No, I think initially you have to present it as a swelling, define the swelling and its extent and surface and all that, and then when interpret it as thyroid later.
Yes. Thank you, sir. Okay, Nikita, when you start off with general examination, why are you asking for consciousness, coherence, and whether the patient is cooperative? If the patient is uncooperative, what will you do? You'll not examine the patient, or you'll take some special extra consent or something of that sort, sedate him. Can you see where the line of questioning can go to? Are you there?
Yes, sir.
So don't put these words.
Yes, sir. Yes, sir.
Don't put these words. These are all for UG level. Consciousness, I can understand. Okay, what are you looking for? Okay, if consciousness also, if he's not conscious, we'll not give him give such a patient for you in examination. Instead, what are you looking for in the patient? Is the patient
You're actually
anxious?
looking for anxious, yes, sir. Nervous.
Why?
It's the feature of hyperthyroidism, sir, and toxicosis we are looking for.
Correct. So don't put this conscious, coherent, cooperative. They're not necessary. They'll just waste more time in the examination rather than help you. And my personal preference, this no eye signs or exophthalmos, whatever you have written, I would prefer you to write this in the last. As in finish your local examination, end it with eye signs, and then move on to systemic examination. Okay? Now,
Okay, sir.
what do you mean by proptosis? What do you mean by exophthalmos? What is the difference between the two?
Sir, proptosis is because of the eyelid. Drooping of the eyelid is called proptosis.
No.
Ptosis. Sorry, sir.
Correct. You missed the prop. What is the difference between the two? I'll tell you the answer because you're short of time. See, both of them are the same. If a proptosis happens in a case of hyperthyroidism, exophthalmos is a specific word for it. So what are the other causes of proptosis? Can be retinoblastoma, some tumor, etc., whatever. But if proptosis happens because of hyperthyroidism, you're going to call it as exophthalmos. Again, a follow-up question. So what is the difference between hyperthyroidism and thyrotoxicosis? One of my favorite questions.
Sir, yes, sir.
Go ahead.
If the hyperthyroidism occurs because of the thyroid gland per se, the main thyroid gland, it is called hyperparathyroidism. But if it occurs due to hyperthyroidism, but if it occurs due to any other causes, secondary causes, or any other ectopic thyroid, it will go under
factitious. Even if the patient takes a lot of thyroid supplementation, even that can cause factitious thyrotoxicosis. Okay, so correct. So if it happens because of overfunctioning of the thyroid gland, then it's called as hyperthyroidism. But if it is any other cause, you're going to call it as thyrotoxicosis. That means toxic symptoms caused because of thyroxine. And the thyroxine need not be from the thyroid, it can be from anywhere else. That's what it is. Now, what?
So for example, in patients with the Hashimoto's, as the thyroid gland is getting destroyed, there will be initial thyrotoxicosis because there is excessive release of the thyroid hormone. It is not production but release of the hormone due to destruction of the thyroid acinine. So there it is thyrotoxicosis, later becoming hypothyroid status.
Correct. Thank you, sir. Now, what are you trying to suggest when you ask for hand tremors, Nikita?
Sir, again, looking for the hyperthyroid feature, sir.
So can you tell me about something else that is similar to tremors, something else that you're going to look for in the patient?
Sir, tongue tremors, sir.
How are you going to examine that?
You would ask the patient to open the mouth and protrude the tongue, but not outside the mouth. And
Where else will you protrude?
Just onto the floor of the.
So just open the mouth and keep the tongue inside. It's not protrude and ask him not to come out. If you mean protrude, it has to come out.
It has to raise a little above the floor, no, sir.
It has to be inside the mouth. If you protrude, okay, tell me why. Why are we specifying that?
So protrusion, they say that some other neurological disorders which show fasciculations will be confused with this. So
So the tongue
Resting.
should be in a resting state, not action tremors. So if you're protruding it, you're using the tongue muscles, and that can cause tremors. Even if you hold something very tight, you'll have tremors. Does that mean you have hyperthyroidism? Yes or
No,
no?
sir. No.
So it should be in a resting state. So if the tongue is inside the mouth, that means you're not using you're not using any muscles of the tongue. And at that point of time, if you find those tremors, then you're going to correlate it to hyperthyroidism, not when you put the tongue muscles into action. If you protrude, you're using your tongue muscles. So that causes tremor. It can be because of this, can be because of other conditions also. Okay. Why have you specifically asked for signs of Horner syndrome? What were you trying to think of?
The involvement of like cervical sympathetic chain in case of malignancy.
Okay.
Looking for the ptosis, meiosis, and decreased sweating, sir. Like losses.
Simple, Nikita. If you have not found another swelling on history, 10 days history, would you expect Horner syndrome?
No, sir.
So better to avoid it. Okay, it's good to know. Let the examiner ask you. If you only give questions like this, you're digging your own grave. Let them ask questions and answer. Okay. Yeah. Next slide, please. Why have you asked for afebrile? In which condition can the patient be febrile? With relation to thyroid.
Thyroiditis, sir.
Anything else?
Thyroiditis.
Anything else?
If it is not a thyroid swelling and if it is an abscess, sir,
In
there could be a
thyroid,
chance.
I'm giving you the answer. In thyroid, with relation, which thyroid condition associated with it, or which condition associated with thyroid can present with the patient having high temperature? If it is very windy outside, lot of rain is coming, what are you going to call it as?
Thyroid strong, sir.
That's all. Hyperpyrexia can be found in thyroid storm. In pulse rate, what are you looking for?
So the first thing is the rate. Second would be the regularity of the rhythm.
Correct?
Third would be the volume.
Okay, volume also accept. Something extra? What happens when you suddenly ask them to raise the hand and you'll put it down? What are you looking for? Anybody else?
Pemberton signs.
Huh?
Pemberton signs.
A. In pulse, why Pemberton sign? Collapsing pulse. Can you have collapsing pulse in hyperthyroidism, in hyperdynamic heart failure? Answer is yes. If I'm asking you the question, that means invariably the answer is yes. Okay, can anyone tell me why you're going to have collapsing pulse? Or what is collapsing pulse first? Anybody? Nikita, Sanya? Not Nikita, sir. Nitya, Sanya, anybody? Okay, simple. See, collapsing pulse means rapid upstroke, rapid downstroke. Okay, when you lift it up, you'll feel as soon as the hand comes down, you won't even feel the pulse. So what does that mean? That means the heart is pumping very fast. That means chronicity, everything is a lot more. And rapid downstroke means there is loss of peripheral vascular resistance. That's the reason it's kind of collapsing very fast. That's the reason it's called as a collapsing pulse. Simple, no? Thyroid hormones, can they act on the heart and cause increased heart rate?
Yes, sir.
Can they act on beta 2 receptors and cause vasodilatation?
Yes, sir.
Can both of these be explained in a case of hyperthyroidism? Answer is yes.
Yes, sir.
If I'm asking you something, the answer is yes. Okay. So you have to know about collapsing pulse as well. Now, do you know of any classification of hyperthyroidism based on the pulse rate?
There is a Kryl's grading, sir.
For what
Based on
pulse
pulse
is
rate.
that? For what pulse?
Sleeping
Sleeping
pulse rate.
pulse.
resting or sleeping pulse rate, okay, which is almost very difficult. We don't do it nowadays because we have better in blood investigations and stuff like that, okay. Again, with regards to blood pressure, what are you looking for?
Sir, it would be high in hyperthyroid state, sir, or toxic state. Same like cardiac.
Correct. So wide pulse pressure. Systolic is very high, diastolic is very low, is again a feature of your collapsing pulse. You're going to find it in the same condition. Okay. Now, Nikita, I'll give you one more thing. Let us say the patient is anxious, tremors, sweating, high blood pressure, has a neck swelling. What do you think is the scenario?
Um,
Jaldi,
Graves'
jaldi.
disease.
Patient also has headache.
Thyrotoxic.
One, yes, thyrotoxic is already finished. I'm asking you for one more. Headache, sweating, hypertension. Which condition? What is this triad for?
Come on, man.
Myocardial infarction, sir.
Huh? Headache, why they'll get in myocardial? They'll
You
get chest
stop.
pain.
Just correlate thyroid with something else, man. Why
Ah.
have you?
Pheochromocytoma.
Ah,
Exactly. So can you have a pheochromocytoma with a neck swelling? What is it?
Men's syndrome.
Men syndrome.
parathyroid, man. Come on.
Okay. So in the exam, see, this is what I'm trying to point out. You guys are so stuck on the thyroid, you're
Association.
not thinking about anything else.
Association. Learn to associate conditions together.
Same thing. If respiratory rate is very high, what do you think it is?
See, I and Nishant have not spoken before this class, but the moment he asks the questions, I know what he is implying. You have to learn to be like that. That is the main thing. Anticipate what the examiner is thinking.
If the patient is having heart failure, you only told no orthopnea, dyspnea, you've already given the answer, correlate it here.
Yes, sir.
Can the patient be tachypneic? Yes. Okay.
Yes, sir.
Next, move on. You have put systemic examination first, but first start with local. Systemic examination comes after local examination. Okay, especially in thyroid and breast or peripheral vascular disease, wherever it is, first local, then systemic, unless you're doing an abdominal examination where abdominal examination comes first. Now here, Nikita, the second line, you have said it is done from front and back. I will accept that statement. Why should the hands be behind the head? I'm asking
For
you
the
something you've
adequate,
written. Huh?
so usually it is used in obese patients, but for adequate visualization.
You told me this fellow is
Usually the
well
prominence.
managed, 40-year-old. Why did you do this for him? Okay, I will let go of that also. What is this method called as?
Pizillos method, sir.
Pizillo's method. Okay, good. Now, simple question. If you do this, when you clasp your hands and look back, what is happening to the fascia?
It's getting taut, sir.
So do you think the swelling should become less prominent or more prominent?
It should become less prominent, but because it is between the facial layers, it becomes more prominent, sir.
What is between the facial layers?
Sir.
What is between the facial
If it
layers?
is thyroid gland, thyroid, sir.
In between which facial layers is it?
Pretracheal and deep cervical, sir.
No. It is behind the deep fascia. And by doing
Yes,
this, you're
sir.
putting the deep fascia, you're making it tight. So theoretically, it is supposed to become less prominent. My question is then, why are you doing it? If something is making it less prominent, why are you doing this method? So that comes down to the point that you should know why you're writing everything on the slide. Okay. So in obese people who have a short neck, because it's like this, you'll not be able to see. So the idea is one, extend the neck by asking the patient to look up because the space here opens up and you'll be able to visualize it better. First point. Second, every time they extend the neck, there is a lordosis that happens at the neck, at the cervical vertebra. So it is pushing the entire tracheal complex forward. So it'll be at least something that was not seen before will be, you'll be able to see it better now. But it is not done routinely. Okay, it has its own problems. That's the reason you don't do it for everybody. You only do it when you really can't see. Okay, don't go to write this in the exam. All right, you can get into trouble because of that. Next slide.
Okay, sir.
Again, so like I said here, please don't mention it as right lobe, left lobe. You're going to start with what is the first most obvious thing that you see on an inspection of the thyroid gland. First thing that you look for. What is the first point that tells you it's a thyroid gland?
Involvement, site, sir. Deglutition.
Deglutition. So if that is the first thing, why are you not putting it up first? Okay. So the minute you say there is a solitary swelling in front of the neck that moves with the deglutition, you are hitting the nail on the head saying that it is the thyroid. Okay. So it doesn't have to come in the last. So this would be my personal preference. I would have presented it like that the swelling moves with deglutition. Then you go on writing everything about the swelling, where it extends, where it goes. We will not get into that. Now you have said something that, okay, which are the other swellings that can move with deglutition apart from the thyroid? Anybody else?
Graduates.
Any thyroid swellings, subhyoid bursa
bursa,
and thyroglossal.
thyroglossal cyst, accepted. Anything else?
Pretracheal lymph nodes, sir.
Excellent.
Any swellings arising from the larynx.
Excellent. Don't say any swelling. The next question will be what are those swellings? Okay, so don't get into that. But subhyoid bursitis, thyroglossal fistula, pretracheal, pre-laryngeal lymph nodes which are enlarged, which are stuck to the tracheolaryngeal complex, will move with deglutition. Okay. One thing else, correct. Why have you asked for doesn't move with protrusion of the tongue?
It is pathognomonic for the thyroidosal cysts, sir, moving with the deglutition.
Why didn't you say it does not move with respiration then? It is pathognomonic for some other abdominal malignancy then. I mean, abdominal growth. Why didn't you do that here?
Sir, because it is a subset in the swelling moves with deglutition, and we are ruling out with the next statement that it is not thyroglossal cyst.
Okay, Nikita, next question. What is the age of the patient, Nikita?
42, sir.
Since when has he noticed the swelling, Nikita? Are you getting
10
the point?
days, sir.
So please see,
Yes,
whenever you're writing, no, just imagine what are the questions the examiner can ask you.
See, the thyroglossal cyst is a midline swelling which will remain midline. The thyroid, though it is a midline swelling, but majority of the gland is lateral. So there is no need for you to, unless you are talking about thyroglossal cyst, you don't have to say it doesn't move with the protrusion of the tongue. If it is thyroglossal cyst, you say it moves with deglutition and it also moves with protrusion of the tongue. So that is the converse is not necessary. Please understand that.
And going to substantiate more, you have said that it is below the level of the thyroid cartilage. Is thyroglossal cyst above or below? Most of the
Above,
times
sir.
it's above, right?
Above.
Correct. So don't get into it. So whenever you're writing negative history, imagine what are the questions that they can ask and avoid it. Okay. Now you have said skin over the swelling appears normal. What scars or dilated veins are you looking for? What were you thinking when you asked this question?
Sir, skin, we were looking in view of if there is any inflammatory changes over the skin or any, if it is a.
What inflammatory changes will you find? with relation to thyroid?
Any redness or any discoloration, sir?
In what case will you find this?
If it is an abscess or infected cyst again.
Of the thyroid. How often have you seen thyroid abscess, Nikita?
No, sir, not thyroid abscess,
Huh?
but
Now you have
cold
said it
abscess
more in
also.
deglutition, and you have defined everything with relation to the thyroid. Then why have you put that line? Okay, so in short, the way you are justifying it is, if you mention it as a swelling and not as a thyroid, you can still say cervical lymph nodes, TB. They could have leaked discharging sinus from a lymph node. Okay. Again, if it is there, mention. If not, don't put it. They will not ask you. Okay. Dilated veins, why are you looking for?
Sir, if there is any retrosternal extension, we can expect some dilated veins to be present.
Where?
Over the swelling, sir.
No. Lower neck and anterior chest wall, not the neck. Neck also you will have, but if you're talking about retrosternal goiter, lower neck and the anterior chest wall. So what is the sign you're going to do to identify retrosternal goiter?
Pemberton sign, sir.
Okay. Now in
We will
this
ask the-
scenario, you have mentioned that it is 2 centimeters above the sternal notch. Yes or no?
Yes, sir.
Can the patient still have a retrosternal goiter?
It can still have, sir. There is a
How?
chance.
How?
It could be an ectopic, some other gland separately, or plunging type of
Next question will be, what is plunging type
ectopic.
of thyroid? What is plunging goiter? Okay, don't get into it, Nikita, please. Okay, it'll just complicate stuff. What instead you can say is a lymph node mass sitting there can cause resonance. I mean, can cause the dullness when you percuss the sternum and stuff like that, but better to avoid it. Okay, if it is there, please mention. If dilated veins are there, mention. If you want to justify it as hyperthyroidism causing increased vascularity, leading to increased venous return, all that you mention. Okay, but if it is not there, better to avoid. Okay.
Nikita, you can't say plunging goiter when you can, when the lower margin of the swelling is well appreciated. So don't make that mistake. See, that will give the impression that you're logically not sound. So I think unnecessarily it will, put you in bad light.
Next, you said trachea appears central on inspection. How did you identify that the trachea is central? Did you use any particular sign, tests, examination? How did you say it is central?
Sir,
On inspection. Have you heard of something called trail sign?
trail sign, yes.
That is what you're going to look for. Prominence of the sternocleidomastoid. Okay. If that gets pushed up, the fascia tends to get tense. So the lower end, it'll be a lot more prominent when compared to the opposite side. So that's why you will make out that the trachea is deviated either towards or away from the side of the swelling. Please read up about it. Okay. It's more of a medicine topic. Next slide. We'll speed up a bit. We'll try to at least finish the examination today in the next 10-15 minutes. No local rise of temperature or tenderness. I would still prefer to skip it in the case of thyroid. Now, inspectory findings are confirmed. Please skip that sentence. You're not confirming. Repeat the same thing if required again. On palpation, I found the non-tender 5 to 4 centimeter solitary swelling, whatever you want. But don't use the word inspectory findings are confirmed. How did you say it is nodular surface, Nikita? That's what kind of shocked me. Hmm? What do you mean by nodular? You should have 2 nodules to call it nodular. Yes or no?
Like irregular surface, sir.
Did this patient have irregular surface? You have written surface was smooth in the previous slide there.
Appears to be smooth on inspection, sir. But On
Okay. I'll
palpation,
give it to you
there was
because okay, fair enough. I've not examined the patient, so I'll give it to you. If you're saying this is, okay, the reason why I'm asking this is because I've seen your diagnosis. In your diagnosis, what have you written?
solitary nodules.
Is this a solitary nodule based on your findings, what you have written? I hope you're getting my point. If you say nodular, you should have two nodules, correct? One over the other, only then you're going to call it as nodular. If it is just one big round thing, you're going to describe it as one single swelling with a smooth surface. Yes or no? This is what I'm trying to understand. I
Yes,
hope
sir.
you got my point.
Got it, sir.
Correct. So if you are writing it as a solitary nodule, you can't write this as a nodular surface. If you write nodular surface, it has to be multinodular goiter. Okay?
Yes, sir.
No, if you have any doubts, you ask me. I will clarify. That's the reason I'm asking. Are we clear, Nikita?
Yes, sir. Yes, sir.
Okay. Now we have
But
said, yeah.
if I mention as an irregular surface, sir, if it is little
Mention it.
non-smooth,
See, there is no harm. Whatever finding is there, you mention it. But you should be able to justify it with your diagnosis. That's why I told, I will accept your nodular surface because I have not examined the patient. I will trust the findings that you have given me. But because I've seen your diagnosis, I know that this and that do not correlate. That is what I was trying to tell you. Change the diagnosis. Mention it as multinodular goiter involving only one lobe. Completely acceptable answer. Did you understand?
yes, sir.
Okay. Done. Lower margin is well felt. I take that answer. Left lobe and isthmus not palpable. Please do not mention it. But now that you have mentioned it, if it is palpable, how will it change your diagnosis? In one scenario,
Sir,
let
it
us
would
forget the nodular surface. I'll just give you two scenarios. One scenario where you can find a nodule in the right lobe, left lobe and isthmus is not palpable. Second scenario, same nodule is palpable, but left lobe and isthmus is palpable.
it would change from the solitary nodule to diffuse goiter with the nodules, sir. Like
Whoa, Nikita, what is diffuse goiter, Nikita? What is the term diffuse? What do you mean by diffuse?
diffuse swelling, which is a multinodular goiter, sir.
No, diffuse means equally everywhere. That is what diffuse is. There is no way you can tell it is one lobe or the other lobe. That's the reason you're going to use diffuse. See, somebody is given the answer there in the chat box. What do you mean by a dominant nodule, Nikita? What is the difference between solitary nodule and dominant nodule?
Sir, if, as you said, if there is a palpable left lobe and isthmus, and there is a nodule in the right lobe,
How will it change your management? How will it change the diagnosis?
sir.
Okay, in short, I will tell you what it is. The first scenario, solitary nodule, I hope you are clear. That means only one lobe is involved, the other two are okay. Other two, when I say isthmus and the left lobe are okay. In the second scenario, the right lobe is obviously enlarged. So there'll be tiny non-palpable nodules, which will lead to enlargement of the gland. So that's why you're able to palpate the gland. So now you have a scenario where you have a single nodule in the first instance. And the second instance, you have one large nodule with multiple tiny nodules in the other two parts of the gland. So what is this called as? Multiple, I can't give you the answer.
Nodular goiter.
Correct. So for solitary nodule, what is the treatment? Hemithyroidectomy. Let's assume the patient needs surgery. Hemithyroidectomy. For multinodular goiter, what is the treatment?
Total thyroid.
So can you see how much difference that one sentence makes with
Yes,
regards
sir.
to the treatment? So don't mention that. Okay, if it is palpable, mention it. Otherwise, just mention it as a single swelling in one side. Rest of it you answer in the viva when they ask you questions. Otherwise, don't go to mention it. Okay. Trachea is central in position. Go read up how you're going to palpate the trachea, how you're going to make sure it's in the center. There are
Within this.
3 or 4 ways of palpating and telling where the trachea is. Carotid pulsations felt on both sides. Where did you feel it? And what else do you look for?
At the level of anterior border of the sternocleidomastoid, at the level of the thyroid cartilage, sir.
Against what?
Thyroid notch. Against the
Huh.
C2 vertebrae.
See? Who is Cristiano Ronaldo? Do you know who he is? Okay, what is Dhoni's jersey number?
7, sir.
For a reason. So C7 vertebra. Okay. It's also called as what tubercle? Chesaine's tubercle. Anyway, all that's not important, but you need to mention that. Okay. At the level of thyroid cartilage and the anterior border of the sternocleidomastoid, where this line joins with the thumb, you're going to palpate it against the transverse process of the C7 vertebra. Now, next question. What else are you looking for? Are you only looking for pulsation?
Displacement, is it in the normal position, or is there any change of the position, sir?
Next question I will ask you. Okay. Okay. Before that, you are also looking for a thrill. Okay. In hyperthyroidism, sometimes the circulation is very high. You might be able to either see a visible pulsation, or sometimes you might see a thrill, or you might feel a thrill. Sorry. Now, when you say displaced, where will you feel the carotid pulsation? External carotid artery pulsation. A common carotid, sorry.
Usually it will be posteriorly displaced, sir.
Just think about it, Nikita. If you have to palpate an artery, do you have to palpate it against a bone or no?
Against a bone only,
So
sir.
if it is displaced posteriorly, what bone will be there for you to palpate? I hope you got the point. Do not
I
say
didn't
that
get you,
I
sir.
felt it behind where it is supposed to be felt. That means it is wrong. Either you're palpated it or you're not palpated it. Simple. Don't say displaced anteriorly, posteriorly, laterally, medially. There is no displacement. It's only going to be palpated at one place. It's either there or it is not there. That's all. Okay? Got it? Nikita, you're
Yes,
there
sir.
or no?
Yes, sir. Yes, sir.
You're there. Okay. There is no posterior displacement. I can tell you that much with certainty. Okay. Next, you finished that. All right. Can we move on to the next one? Next slide. Again, this is a very, very controversial point. Why did you say that the percussion over the manubrium sterni is resonant?
Just wanted to rule out any other ectopic thyroid or any other retrosternal point.
Fair enough. I will take that point. But next question. When you are percussing the lung, do you percuss on the rib or do you percuss in the intercostal space?
Intercostal space, sir.
So intercostal space is resonant. So what will happen if you percuss over the rib?
It is
It is
dull.
dull. So why does percussion over manubrium sternum become resonant all of a sudden?
Due to the presence of trachea, sir.
Bapre, do
In
you think there is more air in the trachea than the lung? Like, and won't the manubrium sternum be slightly bigger and slightly thicker as compared to a rib? That's why I said it is controversial. And the way to defend it, which I've heard people defending, is saying for percussion of intercostal spaces, it's called as an indirect percussion where you're keeping a finger and then percussing over it. Whereas for manubrium sternum, it's a direct percussion where the rib, where you're not keeping that finger in between. Few examiners, I've seen Professor Chintamani say that don't even mention it. It is better you're going to say it is dull. Don't even get into the janjat of saying it is resonant, because according to him, any percussion over a bone is considered dull. But certain examiners will say, no, no, it is resonant. The way to defend it is that it's a direct percussion, where you're using, instead of finger, you're directly percussing on the sternum. And that is why you're getting that slightly resonant note. Okay. Last question. You have said auscultation, no bruit heard. Where did you auscultate for the bruit?
Towards the upper pole of the thyroid, sir.
Why? Which is the artery which gives maximum blood supply to the thyroid gland?
Superior thyroid.
Ah? No.
Inferior.
It is the inferior thyroid. Okay, I'm sure it's the inferior thyroid. Okay, that is what carries the maximum amount of blood supply. But then why did you auscultate for bruit in the superior thyroid artery? Shouldn't common sense dictate that you are supposed to auscultate in the inferior thyroid artery? Okay. Inferior thyroid artery is a single artery or multiple branches?
Multiple branches, sir.
Correct. And superior thyroid artery? You have assisted thyroid cases, right?
Yes, sir. Yes, sir.
So you take it as a single bunch, or you take put small branches of superior pedicle?
Single bunch, sir.
So it's a single artery. So single artery, automatically the blood flow will be more, not the blood supply. The flow will be more because a single artery, like united we stand, divided we fall, correct? So remember that. Second thing, how is the thyroid gland placed? The cartilage, thyroid cartilage. Do you know the notch is in front and rest of the thyroid gland goes backwards? I mean, rest of the thyroid cartilage.
Yes, sir.
The notch is front and rest. So even the thyroid gland will be like this. So the superior pole is more closer to the skin as compared to the inferior pole of the thyroid. So it is a lot more superficial and easy for you to auscultate the superior pole as compared to the inferior pole. Now, of course, we won't have time to go into evaluation and the treatment, but one clinical point. Now, we just kept saying branches of inferior thyroid. Can you tell me what is this importance and what does it translate to during surgery and on table?
It is important for the to look for the recurrent laryngeal nerve, sir.
Why? You're correct. Okay, I would have preferred some answer before this, but I will take recurrent laryngeal nerve into answer. What is the relation between branches of inferior thyroid artery and recurrent laryngeal nerve? Sometimes the recurrent laryngeal nerve can run in between the branches of the inferior thyroid artery. So never take the inferior thyroid artery as a bunch. There is a chance you will knock off the recurrent laryngeal nerve. That is with regards to what explanation you gave. But before that, what is more practical or what you have to 100% look out for is parathyroid gland is also supplied by the inferior thyroid artery. Okay. So one branch goes to the parathyroid, then small branches go towards the thyroid. So you need to take it as individual branches and not as a trunk. Otherwise, if you knock off the parathyroid glands or if you knock off the blood supply to the parathyroid gland, patient will end up with hypocalcemia. Okay. Can you move on to your diagnosis, Nikita? What is this word non-toxic solitary thyroid nodule? Instead, say it's a solitary nodule.
Patient has no toxic sense.
No, I understood it, but I'm saying don't use the word non-toxic. Instead, say the patient is in euthyroid state. If he's in toxic state, I understand. But again, like I said, if it is negative, better to avoid. Use better terminologies. Okay. Start with the anatomical region where the swelling is arising from in your diagnosis. Correct? That's how you're going to start. Yes or no? So first tell it is the thyroid, right? So it's a solitary nodule of the thyroid. Then move on to all the physiological biochemical parameters. Then say whether it's one lobe, two lobes, etc. Then finally go on to say whether the patient is hypo-euthyroid or in hyperthyroid state. Okay?
Yes.
Yeah. So I don't think we'll have time for evaluation and examination. We can probably discuss it with another case or some other time, some non-formal meeting, we can discuss regarding the evaluation and management of a thyroid swelling. We can reduce the discussion then. Ravi Shankar sir, can we do that, sir? Can we
Yeah,
postpone
yeah,
the evaluation?
yeah,
Otherwise, we'll
yeah,
be
yeah,
cutting short.
yeah. I think anyway, when I talked about the thyroid, the assessment was done, but we can definitely, can revise it.
Yes, sir.
Okay.
So, guys, any doubts or questions from your end? If I know it, I'll tell you. Otherwise, I will find out and let you know. Okay. Full pin drop silence. Okay. So,
Uh,
Nikita, well presented, but you really need to work on the wording. See, you know the answers, but if you present, see, you know the concept, you know the answers. But if you put up words like this on the case sheet, and the minute the examiner confronts you, trust me, you will blank out in the exam. So, better to practice getting a pro forma. Okay, like for thyroid, what you're going to write, what are the steps you're going to write. Keep one pro forma, one for thyroid, one for breast. It'll take, you'll just have about one book with, let us say, 30-40 pages where you have written it, and it just becomes a fill in the blanks once you go into the exam. If you get through your entire presentation, okay, quite comfortably, that means you've already passed. If you go into the evaluation and the treatment, at least as an examiner, that means you have passed, and now we are looking at whether you're going to get first class, distinction, or gold medal. So first idea is get through the case sheet quite cleanly without them asking too many questions. They will find out. They will ask something. You have to be open-minded. You should learn how to be calm and try to get answers from other systems. Don't be stuck up with thyroid at that point of time. Ravi Shankar sir, any comments, sir?
Yeah, I think presentation could have been a lot better. I think I think moment you confront her, she gets nervous. So I think she needs to learn to not become nervous, and it's not to frighten you or insult you or anything. I think it is genuine asking questions, which is what the examiners are asking to to find out how much you know. So don't get flustered, don't get tense. Just take be calm, and will take the question for what it is, and just answer calmly. I think that's the main thing.
Sir, if I can just add one more point, Nikita, just revise this case sheet and put it up again. Your confidence
Yes.
will go up 10 times higher once you get things sorted out.
Yes, sir.
So I think you guys understood how much in depth you can go in thyroid and every single aspect of it. So just one, I think what I would suggest is the recording will be available in the YouTube channel. All of you go through this again, so you will, a lot of your doubts will be cleared. Okay. Good night, everybody. If there are no further questions, thank you, Nishant. It was a very detailed class, and
Thank you.
lot
Thank you.
of
Thank you so
lot
much.
of very basics were very well stressed. Thank you.
Thank you so much. Thank you,
Good night.
everyone. Good night and have a good weekend.
Thank you, sir.